So this is the Chapter 21 activity. And we're going to start with Part 1, rock climbing injury. So a 31-year-old male was rock climbing with two friends at a national park 14 miles away from the nearest hospital when he suddenly lost his footing and slid 18 feet to the ground. Both friends who witnessed the fall said that he slid against sharp rock all the way down, landing almost in a standing up position, finally slumping to the ground. The man had multiple scrapes over his anterior torso and a large gash over his right anterior upper thigh near the groin, which was bleeding profusely. A makeshift tourniquet slowed the bleeding, and the friends radioed the park ranger station for help, and the park ranger called for a medevac unit to rescue the man. The helicopter landed and evacuated the man. A large bore IV was placed in each arm in flight, and normal saline solution was administered intravenously. The patient became increasingly disoriented during the flight, reaching the emergency room about 40 minutes after the fall. Upon examination at the hospital, the tourniquet placed on his thigh was found to be soaked with blood. A 6-inch long, half-inch deep laceration was noted in the right inguinal region, extending into the right upper thigh. So number 1, what is this patient's primary problem? Well, he has likely received a cut to the femoral artery and is losing a lot of blood. So this is one of the major arteries that supplies blood to the legs. So he is in danger of going into hemorrhagic shock, which is a type of hypovolemic shock, and this would be characterized by a large loss of blood volume due to an injury. So number 2, the patient's heart rate is measured to be 112 beats per minute while lying supine and 128 beats per minute while sitting up. His blood pressure is measured to be 108/60 while lying supine and 92/52 while sitting up. From what type of blood vessel is blood pressure measured? So to answer that first question, clinical blood pressure measures the pressure in the arteries. Second part, can you explain why the heart rate increases and blood pressure decreases when the patient sits up? So the patient's loss of blood has reduced his blood pressure. That's why he has a low blood pressure. And in response to a reduced blood pressure, the heart rate increases in order to try to maintain a normal cardiac output. This is why his heart rate is elevated. And then when he sits up, the effects of gravity pull the limited blood left in his body downwards, causing a further drop in blood pressure. And this further drop in blood pressure causes the heart rate to increase even more, again in an attempt to maintain a normal cardiac output. Number 3, the patient's skin is cold and clammy, and the nail beds, palms, and mucous membranes are pale. Give a physiological explanation for these findings. So with a loss of blood pressure and blood volume, the sympathetic nervous system will cause epinephrine and norepinephrine to be released from the adrenal medulla. The epinephrine and norepinephrine will cause widespread peripheral vasoconstriction, which is going to be narrowing of the diameter of the arterioles, to try and raise blood pressure and keep the blood supply steady to vital organs. This is going to reduce blood supply to the extremities, like the hands and the skin. Furthermore, with severe blood loss, the vasomotor center in the medulla oblongata will also trigger venoconstriction. That is going to be narrowing of the diameter of veins, and this will mobilize the venous reserve, which is stored in these large venous networks, and shift some of the venous system blood into the rest of the system in order to maintain blood pressure. So one of the large venous networks is the skin. So venoconstriction will divert blood away from the skin and other epithelial linings like mucous membranes. This is why he has cold, clammy hands, and lack of blood to the skin and extremities would also cause pale nail beds, pale palms, and pale mucous membranes. Number 4, describe the baroreceptor reflex. Which of these events would be occurring in this patient? So baroreceptors are sensors that can detect the distension of an organ due to increased pressure on the inside, and they are located in the carotid and aortic sinuses. So I'm going to put up the picture from the textbook that shows the homeostasis of normal blood pressure using the baroreceptor reflex. So when blood pressure rises, the baroreceptors in the aortic and carotid sinuses are stimulated. This is going to stimulate the cardioinhibitory center and inhibit the cardioacceleratory center. So as a result of that, we are going to have a decrease in cardiac output. The vasomotor center also gets inhibited, which is going to result in vasodilation. So this will all lower the blood pressure and bring levels back to normal. When blood pressure falls, the baroreceptors in the aortic and carotid sinuses are inhibited. This is going to inhibit the cardioinhibitory center, try to say that 5 times fast, and it's going to stimulate the cardioacceleratory center, and that is going to result in an increase in cardiac output, aka a higher heart rate. And the vasomotor center will also be stimulated, which is going to result in widespread vasoconstriction. So the increased cardiac output and vasoconstriction will raise the blood pressure back up to normal levels. So in our patient, this is what is going on. So his baroreceptors are being inhibited because he doesn't have any stretch in his carotid or aortic arteries because he's got a low blood volume. And so his heart rate is being increased to compensate, and he's also having that vasoconstriction to compensate. So number 5, describe the hormonal regulation of blood pressure and blood volume. What hormone levels would you expect to be elevated in this patient? All right, so I'm going to put the little chart up here as we go through it. So again, we're looking at homeostasis of normal blood pressure and normal blood volume. So when blood pressure and blood volume rise, the heart muscles get stretched, the atria releases atrial natriuretic peptide, and the ventricles release brain natriuretic peptide. These hormones are going to cause an increase of sodium and water loss in the urine, a reduced thirst, an inhibition of ADH, aldosterone, epinephrine, and norepinephrine release, and then peripheral vasodilation. So the goal here is to reduce the blood volume and to reduce the blood pressure back to normal levels. All right, let's look at the other side. So when blood pressure and blood volumes drop, you're going to get sympathetic activation and release of epinephrine and norepinephrine from the adrenal medulla. These two hormones are going to increase the cardiac output by increasing heart rate and contractility, and they will also cause peripheral vasoconstriction. The kidneys will also release erythropoietin, which is going to stimulate red blood cell formation. The kidneys will also release renin, which is converted to angiotensin II. This is going to cause the posterior pituitary to release ADH, antidiuretic hormone, and the adrenal cortex to release aldosterone. And these are going to increase your sodium and fluid retention and stimulate your thirst. So together, all of these actions are going to increase blood pressure and increase blood volume back up to normal levels. So our patient has suffered a large blood loss. So we know that our patient has a lower than normal blood pressure, and because of his blood loss, he has a lower than normal blood volume. So if we were to take blood of this patient, we would expect to find elevated levels of the epinephrine and the norepinephrine that were released by the adrenal medulla. We'd expect to find increased levels of erythropoietin. We'd expect to find increased levels of renin and angiotensin II, and probably angiotensin I as well. We'd expect to see increased levels of the aldosterone and increased levels of the antidiuretic hormone. So basically everything down here in the bottom of the picture that is helping to restore blood pressure and blood volume by raising it, we would expect to find those hormones in our patient's blood. Number 6, what is meant by the venous reserve? Would this patient be drawing on his venous reserve? If so, does that explain any of the presenting signs? Note there are also elevated liver enzymes in the patient's blood. So 64% of the blood in the cardiovascular system is normally found in the systemic venous system. So in the large veins, the medium-sized veins, the venules, and then those large venous networks in the liver, bone marrow, and skin. And so 1/3 of this blood, so 1/3 of the 64%, which is 21% of the total blood volume, are in these large venous networks, which can act as a reserve of blood. And so with venoconstriction that happens during severe blood loss, blood can be transferred from these venous networks and into the rest of the system, which includes the pulmonary circuit, the heart, the systemic arterial system, and the systemic capillaries. So yes, this patient would be drawing on his venous reserve, which is primarily found in the liver, the bone marrow, and the skin. So we've already talked earlier about how moving blood from the venous network of the skin resulted in cold, clammy skin and pale membranes, nail beds, and palms. And moving blood from the venous network in the liver could also cause some liver cell death due to ischemia, which would be low blood flow in the liver, and this would result in the release of liver enzymes into the bloodstream. So usually when you do see liver enzymes in the bloodstream, that means you have had some cell death of liver cells. Number 7, what factors affect blood flow? Which of these factors are not normal in this patient? So the factors affecting blood flow are the hydrostatic pressure, which is what we call blood pressure. And so as blood pressure increases, blood flow increases, and then vice versa. So I'm going to put little notes over here to show which of these factors will increase flow. And just remember, you can the reverse of each of these is true. So as blood pressure decreases, flow would decrease. The next factor is vascular resistance. As resistance decreases, flow increases. So again, the opposite would be true. As resistance increases, flow decreases. So vascular resistance is driven by two main forces. The first one is the radius of the vessels. And as radius increases, flow increases. And then also the vessel length. And as the length decreases, flow increases. So if you notice, everything I'm putting over here, I'm keeping the flow increases part the same. But again, these are interchangeable. So you could also say as length increases, flow decreases. Another factor affecting blood flow is the viscosity of the blood. So as viscosity decreases, flow increases. You also have turbulence. So as turbulence decreases, flow increases. So this patient has altered lower than normal blood pressure from a reduced blood volume due to blood loss. This would decrease his overall blood flow. Now to compensate, he has widespread vasoconstriction, which is a decrease in vessel radius. Now, while decreasing the radius normally decreases blood flow, so if we come up here and look, vessel radius, as radius increases, flow increases, so as radius decreases, flow decreases. So while decreasing the radius normally decreases blood flow, it also causes an overall increase in pressure throughout the whole system, which can increase overall blood flow in the whole system. So yes, we do decrease blood flow to some areas, such as the skin and the liver, where we had that vasoconstriction cutting off blood flow to those areas. But overall, in the entire system, because we are increasing pressure, we are increasing overall blood flow. Number 8, the patient has a normal hematocrit, 46%. What is the hematocrit and why would it be normal in this patient? Should this patient be given a blood transfusion? If so, what's the safest type of blood to give him? Why? So the hematocrit measures the percentage of formed elements in whole blood. So the other 54% for this patient, because it has to add up to 100, would be the amount of plasma in the whole blood. So as a review from Chapter 19, we can divide whole blood into formed elements and plasma. And then you can further look at the plasma and divide it into proteins, water, and other solutes, and the formed elements as red blood cells, white blood cells, and platelets. And so his hematocrit is in the normal range. And that is because with hemorrhage, blood loss in this case, a patient is losing whole blood. That means they are losing equal amounts of formed elements and plasma. So even though the patient has a markedly reduced blood volume, with the blood volume he's got left, he would still have the same percentage of formed elements to plasma since he's losing both in equal amounts. And that is why his hematocrit is still normal. Due to the severe blood loss, he probably does need a blood transfusion to replenish his lost blood. And O negative would be the safest type of blood to give a patient in an emergency when you don't have time to do all the cross-match testing. It is the universal donor because there are no surface antigens on the blood cells for antibodies in a recipient's body to attack. Part 2, driving can be dangerous to your health, so can long airplane rides. Bill and Emily were excited to see their new granddaughter. They drove 1,200 miles in one day, which was a 19-hour trip, to reach the home of their son and daughter-in-law. As Bill and Emily fussed with the new baby, Emily's breathing began to get heavier. Bill recognized the signs of an oncoming asthma attack. He rushed back to the car to get the nebulizer. He placed the medication in the nebulizer cap, plugged in the machine, and turned on the compressor. He helped his wife hold the mask to her face. Soon her breathing was regular, deeper than normal, but regular. Tired from their drive, Bill and Emily went to bed early. Hours later, Bill woke from a deep sleep. Emily's breathing was labored and she was wheezing. "Are you okay, Emily?" He knew that his wife was awake, but he did not wait for an answer. He opened the bedroom door and turned the light on in the bathroom. He set up the nebulizer, carried it into the bedroom, and gave the mask to his wife as he plugged it into the outlet. Her breathing became more regular, but it was fast. She was wheezing and seemed anxious. Even in the dim light, she looked pale. "I have this pain in my chest and neck, Bill, and it's making its way down my left arm." Bill reached for her hand, and it felt cold and sticky. He placed his finger on the inside of her wrist and felt her pulse racing. "I think we need to go to the hospital, Emily." "I know, but the pain gets worse when I move. It was just an ache before you went to the bathroom, but now it really hurts, and I feel like I'm going to pass out." Bill and his son helped to put Emily into the back seat of the car, and they drove her to the hospital a few miles away. At the hospital, Emily's blood pressure was 90/58, and her heart rate was 95 beats per minute. Number 1. Describe the differences in blood pressures and blood pressure gradients in the arteries versus the veins. Which type of blood pressure was measured in Emily's case? So blood pressure is the highest in the arteries, and arteries also have the highest gradient. And so a gradient is going to be the difference between the highest and lowest pressures. So blood pressure in the arteries ranges from 120 millimeters mercury in the aorta to 35 millimeters mercury at the arterial end of the capillaries. Blood pressure is lowest in the veins, and the veins also have the smallest gradient. So blood pressure in the veins ranges from 18 millimeters mercury at the venual end of the capillaries to 2 millimeters mercury in the vena cava right before they come back into the right atrium. And as we mentioned before, clinical blood pressure is measuring the pressure in the arteries. So number 2, are Emily's heart rate and blood pressure normal? What conclusions could we make from Emily's heart rate and blood pressure readings? So Emily's heart rate at 95 beats per minute is a little on the high side, although technically within the normal limits of 60 to 100 beats per minute. Emily's blood pressure, 90/58, is definitely low. Normal blood pressure is 120/80. Normally, a low blood pressure will stimulate the baroreceptor reflex, which will increase heart rate and restore normal pressure. So Emily does have a slightly elevated heart rate, but her blood pressure is still low. This would indicate that there is not enough blood in the systemic circuit. Remember that blood pressure is measured from systemic arteries. And recall that in our first case study, the patient had an elevated heart rate and a low blood pressure, but he had obviously lost a lot of blood from his wound, and Emily has not shown any signs of bleeding. Number 3, describe 5 things that can help with venous return to the heart. Number 1, even though it is small, the existence of a pressure gradient, so from 18 millimeters mercury to 2 millimeters mercury, still helps with venous return because fluid wants to move from an area of high pressure to an area of low pressure. Number 2, veins increase in diameter as they move closer to the heart, with the inferior vena cava and superior vena cava having the largest diameter. This reduces resistance and increases blood flow as the blood gets closer to the heart. Number 3, the contraction of skeletal muscles in the limbs can compress the veins and help to squeeze the blood in the direction of the heart, while number 4, the valves in the veins of the limbs prevent the backflow of blood, ensuring that the blood continues moving in only one direction toward the heart. And then number 5, during inhalation, the pressure in the thoracic cavity decreases, creating a negative pressure that helps pull blood up the inferior vena cava against gravity, and this is called the respiratory pump. Number 4, describe the factors responsible for movement of fluid, so filtration and reabsorption, across the capillary wall. So I just want to also point out that diffusion plays a role at the capillaries, but diffusion is driving the movement of solutes from their area of high concentration to low concentration. And for this question, we are focusing on mostly the movement of fluid, which is going to involve filtration and reabsorption. So movement of fluid across the capillary wall involves a balance between hydrostatic pressure, which is the blood pressure, and blood colloid osmotic pressure, which is determined by the plasma proteins that are in the blood. So let's put a little picture of a capillary here. So we have our arterial, our capillary, and our venual. So capillary hydrostatic pressure, or CHP, in a normal capillary starts at 35 millimeters mercury on the arterial side and falls to 18 millimeters mercury on the venual side. So I'm putting a red line up here to represent our capillary pressure. So we're going from 35 on this side down to 18 on this side. Blood colloid osmotic pressure, or BCOP, which is due to the plasma proteins, remains steady at 25 millimeters mercury because the plasma proteins cannot cross the normal capillary wall. They can only enter and exit at sinusoids, and those are only present in the liver and a few other places. And so because the plasma proteins are stuck inside the blood, the osmotic pressure remains constant. So now we're going to draw an osmotic pressure up here, and we're going to use a blue line. And the osmotic pressure is holding constant at 25 millimeters mercury, and that is our blue line. So on the arterial side of the capillary, the hydrostatic pressure by the red line is greater than the colloid osmotic pressure shown by the blue line. So there is a net movement of fluid out of the capillary, and this is the process called filtration. So filtration occurs on the arterial side of the capillary. Then, on the venule side, notice that our red line is lower than the blue line, so the capillary hydrostatic pressure is less than the osmotic pressure. So there is a net movement of fluid into the capillary, which is what we call reabsorption. So reabsorption occurs on the venule side of the capillary. Under normal conditions, the amount that leaves with filtration is higher than the amount of fluid that returns with reabsorption, and the excess fluid that leaves the capillary is eventually returned to the bloodstream via the lymphatic system. Number 5. The doctors also note that Emily's legs are swollen. Using your answers to questions number 1, 3, and 4, explain why Emily's legs would be swollen. Why didn't her arms swell? So Emily just spent 19 hours in the car sitting down. And if you do ever have to travel long distances where you have to sit down a lot, like in a car or on a plane, it is recommended that you take frequent breaks and walk around. So on a plane, you get up and walk around. If you're in a car, you stop at rest areas and walk around. So sitting down for long periods of time reduces the muscular compression in the skeletal muscles of the legs that normally assist with venous return. As a grandmother, some of Emily's leg vein valves may also not be as functional as they once were from a lifetime of wear and tear. During the trip, blood began to pool in Emily's legs, so in the veins of her legs to be specific. So as the blood backs up in the veins, the pressure at the venous end of the capillary increases from the increased amount of blood that is sitting in the veins pushing back. So if I put our little picture up here, so normally after the blood flows to the venule, it would then go and return to the heart. But in this case, with her long sedentary period in the car, the blood starts backing up in the veins. And so as more and more blood collects in the veins, that is going to raise the blood pressure because you've got more fluid in these tubes, and that's going to result in an increase in blood pressure. So if I draw my little graph again, remember that the blood pressure originally went from 35 to 18. But now you can see that I've just raised the blood pressure on the venule end just by a little bit. So from 18 to 21 millimeters mercury down here at this end. And that's going to make a huge difference. So if you notice, just by raising the blood pressure at the venule end, the amount of filtration is now vastly exceeding the amount of reabsorption at the venule end. So now we have even more fluid being filtered out than is being reabsorbed. When it becomes too much for the lymphatic system to handle all that extra fluid, fluid then starts accumulating in the tissues, which is what we call edema, and this is what causes her legs to swell. The arms are not as affected by gravity as the legs are, and we also use our arms more even when we're sitting, so venous blood would not back up into the arms. So number 6, the doctors run additional tests on Emily. Emily's blood oxygen levels are low, and her blood carbon dioxide levels are high. Her blood creatine phosphokinase, or CPK, levels are normal, and ECG is normal. Did Emily have a heart attack, a myocardial infarction? So normal CPK levels and a normal ECG would suggest that Emily did not have a heart attack. And if you want to see more details about how CPK and an ECG can tell you whether or not someone's had a heart attack, see the Chapter 20 worksheet and activity. The low blood oxygen levels and the high blood carbon dioxide levels suggest that something is wrong with Emily's lungs. So number 7, the doctor asked for a CT scan of Emily's legs. Why would he do this? What do you think Emily's diagnosis is? So given the symptoms and lack of a heart problem, the most likely diagnosis is a pulmonary embolism. So the blood pooling in Emily's legs during the long car ride would have put her at an increased risk to develop a deep vein thrombosis, or a DVT. And then after she got to her destination and was walking around, that blood clot then became loose and entered her circulatory system. So long periods of inactivity put you at risk for DVTs, and as you age, your risk of developing a DVT during a period of immobilization also increases. So the doctor ordered a CT scan of Emily's legs to search for other blood clots in the legs, which could help to verify the diagnosis. I'm sure he'd also order a CT scan of the lungs. They just threw it in there to be the legs to give you a clue as to what the problem is. Number 8. Explain why a clot from the leg would be more likely to affect the lungs versus the coronary arteries and the brain, causing either a heart attack or a stroke. So let's review the blood flow, and we're going to start with the leg veins, which is where a DVT would have formed in this case. So if we start with a vein in the leg, the blood is then going to make its way up to the inferior vena cava, where it's then going to go into the right atrium of the heart. It's going to pass through the tricuspid valve, which is the atrioventricular valve on the right side, and into the right ventricle. It's then going to pass through the pulmonary semilunar valve, into the pulmonary trunk, which then branches into right and left pulmonary arteries, and then it's going to go to the lungs, and boom. So the lungs, as we head toward the pulmonary capillaries, would be the first time the diameter of the vessels decreases, which makes a clot more likely to get stuck. So as the clot came loose in a vein, remember that as veins head back toward the heart, they increase in diameter. So the clot's not likely to get stuck in any of these veins because each vein is larger than the vein before it. And then the heart has very large chambers, so it's not likely to get stuck in the heart either. So the first time it's going to get stuck is when the vessels start narrowing again. And in this case, that would be as the pulmonary arteries branch into smaller and smaller arteries, and then arterioles, and then capillaries within the lungs themselves. So here is our blood flow from the previous chapter, so from chapter 20. And I added the leg veins up here to show you where the legs are going to drain into the inferior vena cava. And then the question was, why is she more likely to have a pulmonary embolism versus a stroke, which would be a blood clot in the brain? And that would involve the blood clot going from the aorta up into arteries that go into the brain, or a heart attack, which would require the blood clot to go through the aorta into the coronary arteries and then get stuck where the coronary arteries narrow within the heart muscle. And so again, we can see that if we start at the leg veins, we then go to the inferior vena cava, to the right atrium, to the tricuspid, to the right ventricle, to the pulmonary semilunar valve, to the pulmonary trunk, to the right and left pulmonary arteries. And then this is the first time we get to more narrow blood vessels. So in order for that clot to have made it to either the brain or the heart, it would have had to have gone all the way through these very tiny pulmonary capillaries. Then it would have gotten in these large veins, gone through the left side of the heart, gone out through the aorta, and then it would get lodged in either the brain or the heart. And so it's not likely to pass through these tiny pulmonary capillaries, and so therefore leg clots are most likely to cause a pulmonary embolism. And that is the end of the chapter 21 activity.